All right, so welcome everyone to tonight's second COVID-19 update for GPs, community practitioners, allied health, anyone really who wants to come and listen. But a really big thank you to Adelaide PHN for hosting us this evening. And particularly, we have a significant number of presenters and panellists on tonight's webinar, which is fabulous. And the focus for us tonight is going to be on IV monoclonal infusions, particularly focused on the sotrovimab pathway, where we know there's been a lot of interest in this area. So I'll just go through our presenters this evening. Before I do start, I just wanted to acknowledge the land in which we're meeting here this evening, the land of the Kaurna people, for myself or wherever you may be this evening, and pay our respects to elders past, present and emerging who've looked after and cared for the land that we're on today. So just in terms of our presenters tonight that we've got myself presenting, and I'm going to go through a bit of an update. We've had quite a number of frequently asked questions from last week's webinar, so I'm going to focus on going through some of those initially. So apologies if you've just tuned in for sotrovimab, you're going to get some other COVID areas as well. We've got Associate Professor Tom Dodd, who's going to give us a bit of an update on pathology. Dr. Chris Moy, who's here with his AMA hat on as Vice President nationally of the AMA, give us a little bit of an update on the telehealth and where some of those conversations are in the national space currently. We'll have Dr. Jackie Yeo, who's the Carlin GP Liaison Officer, but otherwise known as being the medical lead for the COVID Care Centre at Carlin. And we've got Dr. Rengie Nelson, who's an infectious diseases consultant at the RA, and many of you would know Rengie. And we've got Caitlin Wallace, who's a pharmacist as well, and has been heading up a lot of this work for Carlin, in particular around the pathways and developing these fantastic pathways that we're going to present through tonight. And we have also Dr. Caroline Fegan, who's Executive Director of Medical Services at Riverland Murray Coorong. And Caroline's going to talk through a little bit about the rural pathways as well. So I'm going to get started on the presentation. If there's any issues at all, please let me know and by posting in the chat. However, I will ask if you do have questions to please put them in the Q&A. Then the reason for that is it just makes it much easier for us to track, and also then for following up questions for future webinars, which you'll soon discover I've quickly put into my presentation tonight as I reflected back on people's questions. So the first slide is just a little bit of an update. Since we last met, we've now announced our expansion around the public hospital system, particularly around the additional bed capacity that's come online. So you may recall we've had the RA as being that central main COVID site, Women's and Children's for Kids and Flinders for Obstetrics. We've had to rapidly expand out with the large volume of cases that we have here in the state at the moment. And so not only do we have, the RA and Flinders on board as our tertiary sites, excuse me, just ate a cookie before I started this, and the Women's and Children's. We've also got the Lyell McEwen Hospital that has that opened up now for an additional 100 beds at their particular site, and also very exciting things they're doing with their COVID Care Centre up there, which we'll come to. And also we've got a number of regional sites that are also now part of the program. Just gonna have a drink, excuse me. And we know that a number of patients are already admitted in our regional sites. So it has been a rapid expansion out to the 500 bed plan. The other one I just wanted to update on, as we talked through this last week, was the health system response pathway. And we've just made some slight tweaks and adjustments to it this week. And of course, these slides will be available afterwards. I will tidy them up a little bit because they've been very quickly put together for tonight's webinar, just so they're really clear and can provide the links and interaction then for people to look at this as a slide deck. So as part of this, we have now included the RAT. So we've included that as a criteria there to allow that positive test result to come into the system. It is mandatory for people to report a positive RAT test result, and we've got the system now set up on the SA Health website to enable that. If you do the RAT on someone, or if your patient is unable to use the internet, you can call up the COVID information line, and that particular phone line is now open 24/7, and it specifically has an option you can press to record your RAT result to make it as easy as possible for the community to be able to report their positive result. And it is critical that they do that, because it then allows us then to contact them every day, see how they're going via the SMS system, and also then flags to our public hospital system that person is COVID positive as well. And so we just updated the pathway just a little bit around that. In terms of other areas that we're wanting to focus on and just provide a bit of an update is the great news is we now have a Northern COVID care centre administering the IV infusions, and fantastic work by Dr. Monty and the team up there. So it has been set up as a supported by the GPs from Watapuna, which is fantastic. The Aboriginal Health Service up in Narlan, and an amazing effort by that particular site to get that up and running over the last week, and will be very important, no doubt, as we see increasing cases in the north of Adelaide. As we move through our health system response documents, we are working on stratifying, and we're very pleased to see that there's been continued updates of the National COVID-19 Clinical Evidence Task Force. So we are in the process of developing all of these pathways so they're really clear, and we'll make sure that we can continue to communicate them out once we've had them put into how our SA pathways work. So we have our low, our medium and our high risk pathways, as we talked a bit about last week. We're very excited that we've got Health Direct now that are supporting us. So Health Direct are there to provide that non-COVID care for patients who are COVID positive, and we are actively referring people now to call the Health Direct General Advice line, and that's the COVID line for that further information. And we're very pleased to hopefully have a stronger partnership with Health Direct over the coming months to support low risk individuals in the community. Now, questions that we had last time were the COVID care kits. So you may recall we had these COVID care kits that came out and announced in October, November last year that we would be delivering out virtual monitoring devices to everyone in the state who was COVID positive. Of course, that was based on our 3,000 models, and now we're at our 35,000 cases. So we needed to reflect and see how we would prioritise the kits. So I thought this should just be interesting to answer some of these questions, was around how do we actually prioritise them now. So we focus on our categories, which is immunocompromised, individuals aged over 65 years, referrals that come in from our GP assessment team. At the moment, we're trying to get kits out to as many pregnant women as possible. And also, if you attend one of our COVID care centres, you'll also be given a COVID care kit. Now, what comes in it? Well, I've just got the team to take a quick photo then so we could show you what it is. It's essentially 2 bottles of Hydrolite, 24 paracetamol tablets, a pulse oximeter and a temperature probe. And we also give 2 rats are also delivered as part of the COVID care kits as well, particularly for family members who may need to access those. So at the moment, the only way to be able to get the COVID care kits is through the GP assessment team as part of a referral process. And we are working at streamlining the process actually with our rat collection points. So hopefully we'll have some work happening in that space in the next week or so. We also have kids packs as well, less than 2 and then 2 to 15 as well, just for our COVID kids program kits that are coming through. And you heard from last week, it's about 35 kids a day who are in that program, and that's new children coming in each day, just for that check-in and touch base with our paediatricians. But of course, only those who are most at risk need to be referred into the COVID kids program. Nan and her team at the Women's and Children's have been overwhelmed with inquiries since last week's webinar. So just reminding, it's just for those who are in those really high risk categories. Testing update. Now, this is really Tom's area in the testing space, but I'm just going to give a little quick update on the rapid antigen test kits, just because I thought it was just timely that we just reminded in this space around where we're up to now with what is and isn't acceptable for a RAT result. So, under the new Emergency Management Exposure Sites, Contacts and Diagnosis Direction, and that's the direction that was revised last week, we now accept a positive RAT result. So that means that someone does not need to go and get a follow-up PCR test. Now, what we do say for this, and we have put this out in our GP updates, is that you don't need to confirm with a PCR test if you have a positive RAT. Now, if you have symptoms and you thought, oh, I didn't feel so great, I don't feel like going to the drive-through test site, but I've got a RAT here, then you do your RAT, you're symptomatic, comes back negative, you still should go and get a PCR test. And that's the really big message here. Even if it's negative and you're symptomatic, please go and get the PCR test. Very minimal waits, as Tom will say, at our drive-through sites and testing sites. And this is the time to make sure that you get that PCR test done if it's negative. And I think that's just a good point to remind in that space. And as I said, you can call the COVID information line to report your positive RAT result, or you can do it online. It's incredibly simple, but you do need a mobile phone to be able to do that. So for those who don't have a mobile phone, they can call the 1800 253 787 COVID information line, which is 24/7. Now, a lot of questions about rat supply for primary care. People say, what's happening? It's not fair. We don't get rats in our primary care clinics, GP clinics. This is right at the top of the list of an area that we are looking at. How can we get more rats out to general practice? And we're working with the PHNs, the Commonwealth, and also suppliers around how we can look at a distribution pathway. We have weekly meetings at the moment with the Commonwealth around some of these issues. And this will certainly be on the agenda for this week around how we can look at rat supply, particularly for those people who are seeing patients face to face, and really, really important that we can help with those supply channels as well, as it's been very difficult. We're assisting in the ARCHO space at the moment, but we are looking at what capacity there is from our stockpiles here. So hopefully more information within the week on that, and that will be resolved in a pathway forward with the PHNs, noting that the Commonwealth at this stage is not committed to supplying the PHNs with rats. So that's why we're just trying to work through some of those discussions. So it is there. So please, we know there's been a lot of questions about it, but we do need to be doing what we can to keep the community safe and our GPs and primary care safe as well. All right, vaccine update. I'm trying to get through this really quickly in my 15 minutes allocated. So boosters. So today we've announced that boosters will now be shortened interval between the second dose and the third dose, or the second dose and the booster dose, to a 3-month interval. So ATAGI came out in December and said, once you've got enough supply, enough appointments, please we'll consider moving to the 3-month interval. So we have done that from today. We believe that we need to ramp up, get more doses into arms, and so we will be from today allowing that to change from 4 to 3 months. So that's anyone over the age of 18 eligible to receive a booster 3 months after. And this will apply across all sites who have capacity can certainly start doing that from now, including pharmacies and GP clinics. We also had announced on Monday that there was approval for the Sputnik 5 vaccine, the Russian vaccine, for travellers coming into Australia, and that's a 2-dose course. The other area for vaccine update, just to mention, I know there's been a lot of interest in Novavax, and particularly so, and where that's up to, and that's under consideration at the moment with TGA review, which is good news. Vaccine update. Now, this was a number of questions we had in this space. It's what happens, I've had COVID, I need to get a vaccine. So for primary course vaccination, the advice still continues that the vaccine can be given post-acute symptoms and not to delay the vaccination. Now, we know there is that ATAGI medical exemption that says you can delay for up to 6 months, particularly if people are due for their first dose or midway through course due for their second dose. Our advice still is in this situation to have the vaccine when acute symptoms resolve. Now, delaying doses in children has been the other question as well, and we don't have a position yet firmly given to us by ATAGI in this space. And again, the advice is still to have the vaccination post the acute symptoms resolving. However, this is, of course, under review, whether there is advice to delay by 3 months. But at this stage, it's still very much after the acute infection resolves. Now, the final one, this is the one where I think we're going to get resolution really quick, which will be good, is the booster doses. What happens if you're due for a booster dose, or most importantly, if you're a healthcare worker and you need to have a booster dose under a mandatory requirement, what do you do? Well, ATAGI this week is currently reviewing this in terms of where it sits, but we are looking at whether we delay the booster dose by 3 months, looking at some of the immunology advice in this space. So we'll have a position out by the end of the week, but it is very likely that we'll be providing advice in the direction that you can delay by 3 months from the time of test if you are due a booster vaccine, particularly for individuals who are under a mandatory direction. So hopefully that will answer some questions. And the final point is COVID vaccination should be delayed by 90 days. And we talked about this last week. If you've had a monoclonal IV infusion, you still do need to apply for a CPHO exemption if you are under a mandatory vaccination requirement, and that includes a booster vaccination. And we've already had a couple of exemptions come into the team around this who have had sotrovimab. So that's bit about the vaccination. So I've covered that. I'm going over time, so sorry everyone, but I know we'll get to the IV sotrovimab. I'm just going to quickly cover exposures within community or primary care practices. This has been another topical area in the past week. Now, we have updated our advice on the website around exposures within the primary and community healthcare setting. So this is not about staff coming in who've been exposed in the community. This is about individuals who are on site in the practice. So what our advice is to follow the same close contact definition for staff and clients as they would be in the general community. So this includes around 15 minutes face-to-face indoors, no mask being worn. If you are undertaking an aerosol generating procedure, you're a dentist, you're undertaking a routine dental examination where there is aerosol generated, you should be wearing an N95 mask. This will protect you if you're wearing an N95 and eye protection from being a close contact if you come into contact with someone who is COVID positive. And there's certainly a lot of COVID in the community, so we'd be strongly advising if you are routinely undertaking aerosol generating procedures, you are wearing an N95 or P2 mask. In terms of what it means, though, for staff who've been exposed in the community. So just to emphasise, we are talking about here the close contact definition that we have in this matrix to be utilised. Now, what about staff who want to come back to work? And we touched on this briefly, that this was under review. And at this stage, there are no provisions within primary and community health, such as allied health, pharmacy, general practice, for staff to return to work with additional PPE and RAT testing. Now, we've had quite a bit of feedback that people would like to see change in this space. The risk is currently too great that we're seeing at this point in time, particularly if you've listened to the modelling video. It was a fantastic video that came out on Friday by Professor Spurrier around where we are trending and where we plan to go. The risk is so great at this point in time that we are not looking at making it a routine open general policy for staff within community health or primary care or dentists or allied health to return to the workplace within the first 7 days as being classified as close contacts. Noting the majority of close contacts we are seeing now are within household exposures. So work is underway to develop a framework and approval process for the furloughing of asymptomatic close contact staff members when there is a critical risk to safe service delivery to patients, and particularly focused on regional and rural South Australia. So hopefully that helps explain some of the questions that we've had coming in. We've had comments come in about, well, what happens if it's in the hospital system? We have to be really clear. This is around specific critical workers where there's been specific approvals in place with the hospital for that worker to come in, where that service would therefore result in a negative outcome for the patient if they couldn't return in. So we are working through that to develop a framework and approval process in those very exceptional circumstances. All right, I think I've covered all my non-sotrovimab IV monoclonal referral pathways, and everyone else is probably sitting there itching to get onto the sotrovimab discussion, which is incredibly exciting. And Chris has just posted in the chat as well the modelling video, which is fantastic. It's a really good video to help understand, particularly around school reopening as well. So SA Health statewide IV monoclonal referral pathway. It is a statewide pathway. It's the same pathway for metro rural, which is fantastic. I think this is great collaborative work between the LHNs in the regions and also in the metropolitan area. So we have this statewide pathway. So this is the flow chart, and we will make all of these slides available of how it works. So it's around that referral coming into the system. There's an online website. We're very pleased. It's COVID Infusion. It's really easy, sahealth.sa.gov.au/COVID Infusion. It was a very long URL to begin with, so it's nice and simple. And then it goes across into our ID team, and we're going to get to this around when we come to the Carlin discussion, and no doubt many of you will hear the criteria, so I'm not going to go into that either. We go into this counselling process. There's then a rapid PCR for someone who's not had confirmed PCR, so can't just use a RAT test. You've got to have a PCR before you have sotrovimab, and then you can be referred into the appropriate site. And very pleased that we've now got a number of other sites, and we're also doing outreach services as well through Carlin in people's homes, which is fabulous, and in the aged care space as well. So the focus for this is really around those higher risk individuals based on the risk factors that we know have been set out by the clinical task force. And you can see that particularly in those risk factors for poor outcomes in the areas that we're particularly focused in, and particularly we'll go into the criteria that we have here in the state. So current usage that we're seeing here, very kindly had these figures for something else that was sent to me this afternoon, so I've just quickly put them into these slides, but we've used approximately 460 doses here in the state so far, averaging about 20 to 30 a day, but we expect that will significantly increase now with the number of sites that we have. There are significant pressures though also on the national stockpile for sotrovimab currently, and so there is further work going on in terms of where things are at from a Commonwealth stockpile perspective and what access we can have. So there may need to be some adjustment in the volume of numbers if we cannot get the stock into South Australia. We've had approximately 100 now. This data has come through most recently because we're now started collecting it in the last few weeks, particularly since we've had this new referral process. It's a little bit easier to talk through it. But we can see we've had 40% immunosuppressed, about 60% have been unvaccinated when we look through the numbers. And the main risk factors for developing that severe disease, of course, are being immunosuppressed, obesity, diabetes, cardiovascular disease, and multiple risk factors in a number of these patients that have come in. And we know with the inpatients as well, which we'll come to a little bit in the talk, we've had about 88 so far that have been given since we've had the new process in, and noting that 86% unvaccinated number as well as just of interest there. Just in terms of criteria, we pulled this off our new online referral system. You can see here really where some of the criteria has been that people have selected through the online referral process. Vaccination status has been interesting as well. Of course, it's unvaccinated or vaccinated plus the comorbidities or the required criteria. And the referrals as well coming in. Now, this is just the new system last week. So great job, everyone. You've done a really good job referring in patients, mainly from our GP assessment team, but we've also had other GPs as well referring, other specialists and other as well through different categories in the hospital system. We have a number of care facilities, COVID care centres, and as I said, we do have the new site as well that's up through the Lyell McEwen. It's not at the Lyell McEwen itself, but it's been set up by Narlan, which is fantastic and really, really pleasing to see. These are all primary care GP-led sites, which is fabulous. We've moved away from the ED model and really focused on the GPs running these sites, which is fabulous, I think, for integration as we move forward with the hospital system. And then we've got the rural regional sites as well. Now, I have just listed the sites where we're currently sending sotrovimab out to. So Mount Gambier, Murray Bridge, Berry, Port Pirie, Port Augusta, Port Lincoln, Kangaroo Island, Cooper Pedy, Ceduna, Angaston, down at Victor Harbour, Mount Barker and Gawler. So just for awareness, that's the current sites that we're sending to. There's a pathway online, really easy to get to. You can refer your patients, fill in the online form. You do need a prescriber number. Now, I said, why do you need a prescriber number? I did ask this because I could never remember my prescriber number, but the issue is that you need to have that to verify then if there's any particular issues with your patient. It's felt that the prescriber number would be easier to identify you rather than your provider number if you had multiple provider numbers at different locations. So that was the background. As to why our very clever pharmacists have put that into the system. It's not because your prescriber number is used then to prescribe the actual sotrovimab. So just want to be clear about that. It comes through, these are all our fake patients here. It comes into the system and then it can be triaged based on the criteria and then to the site. So that's all I'm going to give in the brief update. I feel like I've talked enough at 25 minutes and I'm really excited now to hand over to our next speaker. Now, we are going to just move the order just a little bit, so I'll follow the order on the screen and we will come to Associate Professor Tom Dodd next, if that's okay, Tom, from your perspective, because I think everyone's really interested to hear some of the pathology updates from you, and then we'll go to Chris Moy, and then we'll finish off and with the main majority of this evening's talks on sotrovimab with our fantastic guest speaker that we've got. So I'll hand over to you now, Tom, if that's okay.
Sure. Now, I don't know if Crystal was going to project my slides or not.
If not, I can always put them up, Tom.
Thanks, Emily.
Sorry, Tom, I was just having some technical issues. Just share my screen.
You've got it there, okay, Crystal. Tom, you've sent me too many emails.
Yeah, I know. Yes.
Just trying to share my screen currently.
Here we go. Great. Thanks, Crystal. Yes, good evening, everyone. So just pop on to the next slide. Thanks, Crystal. There we go. All right, thanks. So look, I just thought I'd give you an overview of where testing has gone over the last few weeks since things really started picking up. We thought we'd be able to do about 20,000 swabs a day in SA pathology, and then the private laboratories have been very busy as well, as you all know, doing a sort of another 6,000 or 7,000 swabs a day. So we've been at that, around that 25,000 swabs a day mark. What had become quite apparent though, with those sorts of volumes of testing, the sort of ability for people to easily access the drive-throughs, and then for the laboratories to keep their turnaround times where we really wanted them to be, was beginning to drift out. So a few things happened over the last couple of weeks, which has been very positive. The first was a discussion around accepting rapid antigen test positives as indicative of a positive result without the need to have a confirmatory PCR test. And then last week, as you'd all be aware, this decision to utilise rapid antigen testing for close contacts. So in the last few days, the last week really, we've seen a significant reduction in the number of PCR tests, which was close to 20,000 a day, down to what has turned out to be far more manageable volumes for the laboratories. So currently, people who are recognised close contacts can very easily access for free 2 rapid antigen testing kits. They need to register online, and then they can collect those kits. Currently in Adelaide, it's in the South Parklands, and there are locations being set up elsewhere in Adelaide progressively, and there are already sites in the Riverland, Murray Bridge and Port Augusta, with more coming across regional centres in the coming days. It's relatively straightforward to register, and as Emily described, it's mandatory to report positive results, also quite straightforward to do online. And if, for people that find that challenging, there's also that number you can phone in. So what's happened in the last few days, we've now come down to these testing volumes of around this sort of 12,000 a day. That's meant that people can access all the drive-throughs with waiting times down to about an hour. And I noticed our turnaround time, for instance, from the collection of a swab to a result at Victoria Park yesterday was back to 12 hours. So that's really pleasing. We want to be able to turn those results around really quickly for people out in the community, as well as providing those results back into the hospital, so people are getting their COVID results back promptly in sort of clinically meaningful timelines. It was beginning to drift out, become really challenging with those high volume testing. And we know that the RAT tests are providing good coverage and positive results. They're flowing through the system now, so they're triggering the same results back to the CDCB and also into the care pathway. So I think that's worked really well and sort of preserved the PCR testing capacity. So we'll just pop onto the next slide. So this one shows at the edge, I don't know whether it's probably hidden by all our pictures, but I don't know whether it does or it doesn't, but anyway, at the end, at the edge, it shows this spike in the positive rate in each of the COVID testing, which has gone up to about 21% swabs have been COVID positive in the last few days. But what's pleasing is it's now beginning to come back. So today, the positive rate was under 18%. So that's beginning to decline. And at least for me, maybe that's a sign around where we are in terms of closing in on, or maybe have reached a peak. You know, there's some other information that's potentially suggesting that as well. But certainly from my perspective, I think that's really interesting that the positivity rate is beginning to decline just slightly now, which I find very reassuring. Alrighty, so the next one, Crystal, thanks. So something else to bring to your attention is another direction change which came into effect last week, and that was about the use of PCR testing. As I described, obviously, we were beginning to reach the limit of the labs in South Australia's capacity to do PCR testing. And obviously, as you'd all be aware, this has been a national problem as well. So a direction change came into effect, which basically preserves that PCR testing for patients who are either symptomatic or where there's a clear indication for PCR testing. So for community patients, what we're saying is we'd like people who have symptoms, in fact, obviously actively encourage anyone with symptoms to get a PCR test, but for the most part, asymptomatic people shouldn't be having COVID PCR tests out in the community. Obviously, within the hospitals, there are a range of indications for PCR testing, and they're obviously processed. Similarly, requirements around travel, particularly international travel requires PCR testing. And the last point there, persons with a positive RAT result could have their test confirmed by PCR testing. However, at the moment, a positive RAT result is regarded as diagnostic for COVID. So it's not a requirement to have a PCR test to confirm a RAT result. We'll hear a little bit more in a few moments, I'm sure, about where active therapy is going to follow on the basis of a RAT-only test, and a PCR test would be sensible to do. The graph just shows the decline in asymptomatic testing. So the bar graph, the green bars are the asymptomatic testing, and that was pretty close to 2/3 of our tests were asymptomatic testing, and that's come down now to under 40%. So I think that's really good. It's preserving the capacity to do PCR tests in a sort of timely fashion, both in terms of collecting those swabs and not having people queue for many hours, and also getting the results back to the patients and new folks who are waiting on the results. So just to be aware of that change in the direction. And then the next couple of slides are really around where the Omicron has effectively almost extensively replaced Delta. So this is a rather colourful display of all the various sorts of variants that we've had for the full duration of the pandemic. And as you can see, sort of just off to the centre is the pink Delta, which dominated for so many months. But over the last really since the borders opened, as we happened to coincide with Omicron, how very quickly that's displaced the Delta, with very few Deltas being identified now. We'll just go on to the next graph. Same sort of thing again, just a different way of displaying it, with the Omicron in the blue on the right now really occupying more than 95% of the virus types that we are sequencing at the moment. Originally, we were doing whole genome sequencing on every single positive case. Now, clearly that wasn't going to be sustainable. We were diagnosing 3,000 or 4,000 cases a day. So what we're doing now to ensure that we've got good insight into the variants is sequencing patients from any cluster. So if there's a particular outbreak, for instance, in a prison or an abattoir or so forth, and also very extensive sampling of inpatients and certainly everyone in ICU. So we'll just go on to the next graph. So this gives, once again, a bit of a representation of what we're seeing in the patient population on the left, non-ICU patients, and also some of the community where obviously Omicron now is really by far the dominant variant, extensively replacing the Delta. Within ICU, for the cases that we've sequenced to date, that's obviously changing as well. Delta clearly being a severe infection for more patients, causing pneumonitis more frequently, occupied a bigger proportion of the ICU patients. But as you can see, that's shifting as well. We're seeing more Omicron patients in the ICU, but still the sort of the tail of the Delta in the ICU patients. I would anticipate that'll continue to decline as the Omicron dominates the variant profile in the coming couple of weeks. So that's just a bit of a snapshot. Everyone's pretty well aware of it, but it's interesting to see our local experience here in South Australia. And I think that wraps me up.
Thanks, Tom. I think everyone will find that really interesting to see the graphs, and particularly as we move forward around ICU presentations as well, and it'll be very interesting to see if we continue to see Delta coming through, particularly in those cohorts. It's great that South Australia is able to track actively what's happening in that space. So thank you, Tom, and please keep questions coming into the Q&A box if you have specific questions. Tom's covered a lot of really key areas, and also around the changes to PCR as well for asymptomatic, which is fantastic. So thank you, Tom, as usual, for your expertise in this space. I'm now going to move to Dr. Chris Moy to give us an update from the AMA and particular areas around telehealth as well. Chris, I'll come to you now. Do you have your slides or does Crystal?
Yeah, I've got my slides. So,
Fabulous. All right.
I'd like to
Thanks,
share.
Chris.
Am I allowed to share at the moment?
Absolutely, you should be able to.
Just hang on a sec. I've just got to do something which is quite serious. Just remove that. Sorry about this.
And just for everyone's awareness, this is being recorded and will be available within the next day or so with the slide set as well.
Sorry about this. Just bear with me just a sec. Got to do the old share system preferences.
No worries, Chris. I can just keep talking anyway while you get your slides up. So we had a question that's coming into the chat around using PCRs in aged care. So we are currently reviewing the role of PCR testing in aged care. You're absolutely right; it is still being utilised, and we are moving towards rapid antigen testing in aged care facilities. Very
Crystal,
soon.
I might have to get you to do it if you don't mind. I've just got this slide issue.
Yeah, I think you might have to unshare for Chris to share.
Okay.
Did you want me to share them, Chris? I can do that
if
now.
you don't mind.
Yeah, that's fine.
Then we had another question come in here. People are being, so these are the ones in the chat. Please put your questions in the Q&A, but I'll answer ones in the chat so we don't miss them. Being turned away for travel-related tests when asymptomatic. That is one of the criteria, and the direction is you can have a PCR test if you're needed for travel-related purposes. So I hope that was just a lone case. And we've got the slides up, so I'll stop talking.
So I'll be pretty rapid fire as I normally am. The first issue is with regards to boosters. So that's the first thing. Click it if you don't mind, Crystal. So the first thing is just to remind you of the matter. I think about pregnant. A lot of people are not remembering about pregnant women, that they really need to get a booster, and it will be from 3 months from now on. So really, they're a priority. And also, immunocompromised individuals now can get essentially a booster after their first 3 shots. So it's a 4th shot. So it's really important that people remember that. And it's going to be much more relevant now because of the 3-month thing, because it's brought them back right into play at the moment. So please remember that. Next slide, please, Crystal. We'll just talk about COVID care funding and telehealth. So next slide, please. So just with regards to the COVID care funding, you know, that $25 if you're looking after somebody with COVID face-to-face. So that's now been opened up for rapid antigen testing, but it's important to remember that if they have a rapid antigen test, you are required either to assist or confirm the reporting of a positive rapid antigen test for that patient to the relevant state or territory reporting system. So that is something to just keep in mind. I'll put the link up for this a bit later in the chat. Next slide, please. The next thing I'll just talk about is the thing that a lot of people busted their guts over the last few weeks trying to get the booster dose $10. But funding for $10, but also this to open up a level C. So now there's essentially a level C available for telehealth for telephone. So that's really the big one that's you've probably heard about. Now, this is item 92746. Now, unfortunately, there still is a requirement for one face-to-face service to the patient in the 12 months preceding the telehealth attendance. Now, we are working on this to see if it can be opened up. They're really trying to stop the pop-ups, and also, unfortunately, what's happened in the past is that some pop-ups have occurred to take over a lot of the rural type care, which has broken up rural care and actually undermine the rural practices. Next slide, please. But we are working on it. But just remember, the established relationship requirement does not apply to children under the age of 12 months, people homeless, those patients receiving urgent after hours and social hours service, or patients or people who are isolating because of a COVID-related state or territory public health order, or COVID-19 quarantine because of a state or territory public health order. So it's actually already in play for those patients, and that's going to be quite a lot of them at the moment. Now, the other thing is that the item, due to time constraints, it's not been possible to amend the legislation that establishes 100% rebates for GP, but the rebate for these items is paid at 85% of the item fee, and the fee amount's been increased so that the Medicare rebate for the service is the same level as equivalent rebate for a level C consultation. So it will just look a bit funny in the actual MBS rules at this stage, but it will be the same amount. Next slide, please. Look, we are trying to still work on the government to get some block funding for payment for practices for COVID care, mainly to take all the phone calls I know many of you are getting at the moment. They are still looking at it. We've got another meeting with the Minister for Health on Wednesday. Just also know that we have advocated AMA, RACGP with Danny, and also the Guild have worked with the government here locally, and the Premier has announced that extra funding for those willing to apply for it, for extra funding for booster shots. So I think it's an extra $15 in Metro and $25 in the country if you're willing to go the extra mile and to help you sort of fund extra services a little bit outside the square to really push on with the booster effort in South Australia. Next slide, please. We are still working on the rats issue. Now, the problem is there's just not enough rats, and really the priorities for rapid antigen tests are really aged care, rural, Indigenous, and they're the key three. And I know we all want them but it's I mean, it's been a bit of a disaster, frankly, and one of the unfortunate failure from a federal point of view, particularly. But unfortunately, we at AMA is still advocating that those areas get it first, because that is far more important at the moment. PPE, we're trying to get the feds to make sure that we get the right PPE that's fitted for us, and also to get some pulse oximeters, but there just aren't that many of them, even though they are in the COVID pathways for mild to moderate for those people with some risk factors. Next slide, please. Yeah, it's a priority for rural and Indigenous. We really do understand they've got to be defended, the rural. So for those of you working in rural, we understand we are actually advocating extremely hard for you, because we get the dangers. Education of patients. Yeah, next slide, if you don't mind. So just to emphasize again, I would be definitely pointing to, I'd put it on your website, onto your social media things, to get your patients to have a look at the Health Direct site, and also point them towards the National Coronavirus Helpline, because they may be able to absorb some of the phone calls and queries that they're calling you up about. And also this symptom checker is extremely helpful, based on the National COVID-19 National Evidence Task Force, just to give information about when patients should go call an ambulance and when they should be calling you with COVID. So very helpful, even from your point of view, to know what your patients are reading on that website. We are really trying to get the word out that patients at least have a resource, because that's been a missing link, and that's why we're getting a lot of phone calls which are inappropriate. Next slide. There has been, you may have heard, there's been a PCR deferral. So there's deferral of they were going to start looking very carefully about telehealth being brought into this 80-20 rule, and also have a 30-20 rule that was going to be applied. Because of Omicron, they've removed that, and they're not going to start looking at this at least until mid-year, because they understand the serious requirements to provide health at the moment to a lot of our patients. Now, the other thing is electronic prescribing, and also we worked very hard to get additional extension of the image-based prescribing arrangements until 31st of March 2022. I'm not sure they've got much. I'm going to warn you now, if you haven't started electronic prescribing, you really should be, because there isn't a lot of appetite for the government to go much past that, I don't think. We will try again if needed, but they're very, very reluctant to go. We have had to work very hard to get them to go so we're talking about the faxing, and you know, we'll have to go back to the old ways otherwise. But really, if you are not using electronic prescribing at the moment, I would strongly advise you to get your act together with that, because it's the way we're heading. Okay, next slide. Just Health Pathways South Australia. Just final slide. I'm going to point this to you again, because it's just really good. It's got the pathways of how to manage COVID in the community, and really we should all be looking at this very important thing, and has links to pretty much everything. And that's pretty much it for me. Can I just ask one final question? This is for Emily, actually, because this is just clarifying on the Q&A. Just to clarify, so I've spoken to you and also Nicola about the matrix revision for community health. You gave a bit of you brought it up a little bit earlier. So I understand. I've talked to Nicola also about the need to have slightly different rules, probably in country, because they really need it. But do you have any idea when that's going to come out? Because that's really Bridget's question, I think.
Yeah, no, thanks, Chris. Within the week, I just had a look at it then before I came to this webinar. I just was just talking through with Nicola around how we're going to look at making this really simple. I can't stress enough. People who know me know that I just love things documented. I'm like the queen of documentation, which is why I love this job. So we are absolutely really keen to get out a simplified document. It will not be a matrix per se, where you'll see coloured graphs and different ways that you follow it. The advice is it's the close contact definition that we're currently using, 15 minutes, close contact, face-to-face, indoors. If you've not been wearing a mask, and it's a surgical mask, and your patient's not been wearing a mask, then you are classified as a close contact. Aerosol generating, you need to be wearing N95, P2 and eye protection as well. But within the week, that will be, I mean, it just has to go through the process. Things have to be approved. There's certain approval processes we now have in place for all documentation that goes out. So it just needs to go through that official process. Now, in terms of the staff furloughing, that's a different piece, and that will come as a separate document. It won't be in that document, be a separate document. And as Chris said, we really are focusing on the rural and regional practitioners where there's a critical need to be able to work, and we're setting up that process over the next few days. We do still have our exemptions team operating and functioning in those rare occasions, and we've had to do that for aged care, for instance, at the moment, but we are really keen to be limiting wherever possible people returning to the workplace in that 7 days, because we're just seeing so many people test positive. The transmission rate currently is just so considerable when you look at the household transmission that we're seeing. So that's why we're very reluctant to move that position at this point. Hope that answers it, Chris.
Thank you.
And just for awareness, we do have the grant payments. I didn't talk on that at all, but Chris gave a little bit of an update for vaccination for boosters. And we are setting up a regular GP group that will be with the RACGP, ACRA, and rural doctors and the AMA to meet regularly around some of these critical issues in primary care, particularly focused on vaccines to begin with. And this was one of the initiatives that came out of this was having grant payments similar to what Victoria's done. So that's fabulous. So $15 per dose for Metro, 24 regional rural, which is fabulous. All right, great questions coming through. So we'll move now we'll focus now on what the purpose of this webinar was, the Sotrovimab, and go through some of the updated guidelines. I'm going to hand over first of all to Jackie. I think we've got Jackie online. She's there, and she's going to give us a little bit of an update where things are up to. And as many of you know, Jackie's become the queen of Sotrovimab. Anything you need to know, Jackie knows about it, and she's got her wonderful group of colleagues as well on the line with Caitlin and Renji. Both have been doing so much in this space to really make it as safe as possible for everyone. Now, Jackie, do you have slides? Fabulous. All right, we'll hand over to you.
Jackie, would you like me to share your slides and you can unmute and talk to them?
You might need to unmute yourself, Jackie. Just while that's happening, I'll just cover a couple of things in the chat just to keep this going. So this we are working on getting GPs looped into results. It's not happening yet at this stage in terms of routinely being added in, but we are working on that actively, Julie, to get that happening, because we agree next steps moving forward, we need to get GPs on the results, and we are actively collecting that information if people are reporting it to us within SA Health once they've tested positive. We just haven't done anything with it yet, but we are looking to do something with it to keep you informed. All right, I'll hand over to Jackie.
Thank you, Emily. And thank you also to Katie Wallace, who has been very kind and let me cheat off her slides. So they look much more beautiful than mine would have done. Crystal, if I can get you to move on to the next slide. Okay, so basically what we're looking at is the referral process here. So confirmed COVID positive result, and we'll talk a little bit about the PCRs versus rats a little bit later on, but definitely needs to be a PCR now, and there are ways of facilitating that. We need to get referral really within 7 days of symptoms onset, because after that period, Sotrovimab and Ronapreve are not effective. So it needs to be within that time period. There is a limitation. There are several sets of criteria, but essentially what we need is that the person has to be immunosuppressed, and we'll talk about what that means in a moment, or unvaccinated or partially vaccinated, and also have risk factors for progression to severe disease. So being immunosuppressed or unvaccinated by itself, you also have to have those risk factors. So it's the combination of the two. You need to complete an online referral form, and I've seen that link being put into the chat, which is great, and it is a much simpler link, so thank you very much for that. It's making my life a lot easier. And then that goes through to an online portal where the referral is caught by our fantastic DASTIS drug and therapeutic information service pharmacists. Many of you in general practice will know these people because they have been coming out and visiting you for many years. They are experts at this by now. They've learned very quickly, and they will look at the referral, see if it meets criteria. If there are any questions about it, they will then refer that to our infectious diseases specialists, and in the case of our pregnant patients, to the obstetricians in the LHN that is looking after them. So that is the initial process that goes through. Could I have the next slide, please? Okay, so basically, yes, you've got to be COVID positive. You've got to be COVID positive to get into a COVID care centre at all. Thank you. We don't take anybody who's suspected COVID, and we can't take anybody who is COVID negative. So that's really important to start with. But you've also got to be COVID positive for obvious reasons to get a monoclonal antibody infusion, because they're not cheap drugs. It's got to be a Pcr test. Positive rat, we can expedite it, and we will expedite it for you, but it's only if the person is going to have a monoclonal antibody infusion. They've got to have been symptomatic for less than 7 days, as we said, and they must not be on oxygen because that's a marker of more severe disease, because that means that they need to move forward in the pathway to other kinds of therapies. They need to be immunosuppressed, or they need to be unvaccinated and partially vaccinated and have a risk factor or risk factors for developing severe illness, exactly as we've got here. If I could have the next slide, please. Okay, so the immunosuppression conditions, and all of this will be on the website. So Emily promises me, which will be wonderful, but it's also embedded in the form. So you'll see as you go through the form that this is actually part of what they're looking for. It needs to be either an active hematological malignancy, so leukemia, lymphoma, those sorts of things, or a non-hematological malignancy, but they've got to have current active treatment, which means chemo or radiotherapy. It's either a solid organ transplant with immunosuppression, which most of them do, or a stem cell transplant recipient within 2 years of transplantation. Primary immunodeficiency, well, those are interesting and rare conditions, but they do exist. And yes, we need to be aware of those. And obviously untreated or advanced HIV, and how many of those we'll see, I don't know. I haven't seen any yet, but certainly they would be considered immunosuppressed. If we could have the next slide, please. Okay, and then going on now, high-dose corticosteroid treatment, as it says here, more than 20 milligrams per day of PRED for more than 14 days in a month, or pulse corticosteroid therapy. So that catches some of our asthmatics, and it catches some of our rheumatology patients. There's a number of different patients that come into that. The disease-modifying anti-rheumatic drugs, and there's a list there, but I won't go through, but it's all included. The one you don't include is Plaquenil or hydroxychloroquine. When it's the only drug that they're on, that does not come into the criteria. If they're on multiple immunosuppressants, combination, these are the patients that we really want to catch, guys, because these patients are high risk, and these are the ones that are most likely to end up in ICU. And looking at the data around ICU and who we've got in there, that's absolutely clear. So we really want to catch them, and that's why I've been making such a song and dance about getting this information out to as many people as possible. And it is fantastic that we have so many GPs looking out for these people, so many specialists, because that's how we're going to find them and find them quickly so that we can get them treated. There are also biological targeted therapies. There are some that don't come into that group, and again, that information will be on the website. But look, if you're not sure, make the referral. If it gets declined, it's for a good reason. And I'd rather you made the referral and it gets declined than you don't make the referral and that patient is eligible, because I really want to catch these people as much as we can. Next slide, please. Okay, so partially vaccinated, always an interesting question, but we're getting some clarity on it. Obviously, if they're singly vaccinated, they've only had one dose. If it's less than 2 weeks since their second vaccination, if it's more than 4 months since they've had their second vaccination of AZ, or if it's greater than 5 months since their second vaccination of Pfizer or Moderna, or if it's less than 7 days since any booster vaccination. Goodness me, there's a lot to remember there, but it's not as difficult as it sounds. And again, it will be obvious in the form as you go through. The most important thing is to put in those dates of vaccination and be very clear with your patient. And you can find them on the patient's My Health record in the Australian Immunisation Register section and also in the immunisation section. So it's a lot easier than it used to be. There are ways and means. Next slide, please. Okay, so the risk factors. Now, there has been some tweaking of this, and our GPAT team will be a little bit, they will see that there are some changes already, mostly around obesity, but these will be changed according to stock availability. So basically, if we don't have as much stock, they may need to be tightened up, and it will be a flexible sort of thing. Definitely diabetes or gestational diabetes. Well, obviously, you've got to be pregnant to have gestational diabetes. That's a fairly obvious thing. Obesity, BMI of more than 45 kilograms per meter squared. As a general, it used to be more than 30. Now it's more than 45 as a standalone. If it's more than 30, it's got to have at least one additional risk factor. So that's a change that our GPAT people will recognize. Chronic kidney disease, and there's some definitions there about what that actually means. If it's more than, if it's 30 to 60 EGFR, you need to have an additional risk factor. So this is much clearer than we had before. Congenital heart disease, which again is a much clearer indication than cardiovascular disease. I know that was confusing before. This has all been much more tightened up. Congestive heart failure and the New York Heart Association class 2 or above. And that classification is easily available online, so you can Google it and find it. Chronic lung disease, and as you can see there, COPD, emphysema, chronic bronchitis. These are the sorts of things we're looking for. Asthma, we've already talked about the course of oral steroids in the last 12 months, and that would fit your criteria for higher dose prednisolone as well. And certainly people who are on an inhaled steroid, but it's moderate to severe. So it's the people who end up in hospital when they go bad, particularly the ones I want to find. Chronic liver disease, again, if they're immunosuppressed or they're partially vaccinated or unvaccinated, so not by itself. If they're more than 55 years of age, if they're non-Aboriginal or Torres Strait Islander, and more than 35 years of age if they're Aboriginal and Torres Strait Islander. And exactly as we said before, Indigenous people are at such risk. And again, that's a group I really want to try and catch as much as we can, because they are so challenging if they get sick. It's really difficult to have somebody who is isolated in a hospital room away from their mob. It's a terrible thing. So to try and keep those people well is really important. Immunosuppression and pregnancy and breastfeeding is not a risk factor, I mean, in itself. It's just that those factors may mean that we need a little bit more counselling. So please don't see those as risk factors as such. It's just that means that we might need to have more of a conversation around risk and benefit with the mother, with the woman involved. If I could have the next slide, please. Okay, so basically what happens is that if you're a GPAT doctor, you ring the person. If it's a normal, sorry, not a normal GP, if it's anybody GP or a specialist, patient gets in touch, says that they're COVID positive. You'd happen to know that they're immunosuppressed or unvaccinated, partially vaccinated, and by all means, let your patients know to ring you, please. It's actually very helpful if we pick them up early. Obviously, assess the patient first, and you want to know the number of days since symptom onset. You also want to know if they're well, because if they're not well and they're starting to go downhill in a major way, they need to go to ED. We're not going to be dealing with them with sotrovimab out in COVID care centres. Thank you very much. chuff them off to ED, and no shame in that. If it's mild symptoms and it's less than 7 days, that's when you do your online referral form, and it goes through to the Dartis pharmacist, who will then send it through to us. And you saw that little spreadsheety kind of SharePoint thing before, which Catherine Hughes, sorry, beg your pardon, Catherine, has put together so beautifully, and which we're all getting our heads around now. And then that will come through to us at the LHNs to counsel those patients if they're happy to go ahead, book them, and then to organise which LHN they're going to be seen in. And there will be a lot of cooperation around that. There has to be. Next slide, please. Okay, so I've just said it all, haven't I? So basically, when we talk to the people around the infusions, we essentially tell them that they're lovely drugs to work with. They don't have much in the way of side effects. Chills, maybe a bit of a headache, maybe some dizziness, maybe a rash. You can tell I've said this a lot, can't you? And maybe a bit of nausea. But really, we don't tend to see them during the infusion. And maybe the night of, because we do a follow-up phone call the next day just to check on them, maybe the night of they might get a little bit of loose bowel motions and possibly a mild headache, but that's really the sum total of it. Anaphylactic reactions are as rare as hen's teeth. And I keep telling all of our patients that we haven't seen one yet in Australia, and I hope I'm still telling them the truth, but I think I am. So really, the only thing that, again, with pregnant women, there's the whole thing about fetal anaphylaxis, but I imagine that's as rare as it is in adults as well. However, that's why the obstetricians come into the pregnant women. We will then go ahead and prioritise the infusions according to when the infusion needs to be completed. And, some of the other relevant risk factors coming into it. So if I've got a patient with cystic fibrosis or a patient who's a solid organ transplant, or those really high risk ones, obviously we're going to try and catch them and do their infusions as early as we possibly can. And I have liaised with all of those teams to really get their attention up and focusing on them. We basically book the time to negotiate transport. If they can drive themselves or someone else can drive them, fantastic. If they've got someone else COVID positive in their life, I get very excited and I think it's wonderful. We've had one interesting young woman who used an Uber. Please don't tell them, not that any of you would do it, but obviously they can't use an Uber, they can't use a taxi, and they cannot use public transport. And we do send them a text message just to let them, if they just on the off chance that they get stopped by police, that reminds them where to go, tells them the phone number, and just tells them logistics, and then they can show that to the police if they get stopped. I don't think we've actually had anybody do it, but just in case. And that reassures people, because they get a bit nervous about getting out and driving their car when they're COVID positive, because they're a bit scared they're breaking the law. Next slide, please. Okay, and yes, we will absolutely be talking to each other, and particularly our rural LHNs, because I know that they are under a lot of strain. They're very vulnerable in the sense of there's not a lot of people on the ground to do the infusions. So if somebody gets furloughed, it makes it very challenging. So there will be a lot of negotiation and cooperation going on between LHNs. And I've just been in contact with Sharon Morton about a patient that I'm trying to organise an infusion for at Owens. Which I need a map of South Australia to find all these places, but even though it's not in her LHN, she will help out if necessary, and so we'll get that patient infused. That's how it works. In terms of the exemptions for mandatory vaccination, yes, it does have to go to the Chief Public Health Officer, as Emily said. We provide a letter to all our patients saying that they've had a monoclonal antibody infusion and confirming that it's not recommended that you be vaccinated for 90 days after that, because the vaccination response is blunted. They can then take that to their usual GP, or I suppose email it to their usual GP or whatever, and then that can be used as the basis for the application for exemption. But as you'd understand, we're getting so many people coming through. We're averaging between 15 to 20 a day at the moment, and that'll go up. So we really do rely on the referring doctor or GP to make that application. And thank you for doing it. Next slide, please. Okay, some very practical points. Please, please, please. Phone numbers that are entered as 04 or a series of zeros makes it very difficult to do anything further with that referral. We can't contact the patient, we can't do anything with it. So my approach to that is to contact the referrer. And if you get a phone call from me or someone else, that's because you haven't put that phone number in. Please do it. And thank you so much for doing it correctly. If you can check the spelling of the name, that would be great as well, because we've just had a few where the spelling was a little bit off and it creates some confusion. If you can make sure that the patient actually wants you to put the application in and would like to have the infusion, that would help us too. It's fine if they're not sure. It's fine if they want more information. Really happy to deal with that. But if they really don't want the infusion, there's not a lot of point in putting in the application. But feel free to use the information sheets that are on the website. They're good. They're the information sheets that we use as well, and they're very good. Please tell them to expect the phone call from a blocked number. Oh yes, and please put the Medicare number in as well. Yes, thank you very much. That would be useful too. If they get a phone call from a blocked number, please to pick it up. We do try repeatedly, and we try over a course of 2 to 3 days, but at some point you have to give up. We do our best. We will definitely contact them within a day or two, but please don't get them to call us because it's too time consuming for staff. We'd love you to give us a ring if the patient is day 6, and especially if they're day 7, because that's so time critical. We want to try and catch them. So I've got the phone number for the Carlin COVID Care Centre in one of our slides. Yeah, so if you could give us a call or send me an email or whatever, it's very helpful. Please don't send them to ED. We have had some, and understandably, because people didn't quite know what to do with them, where people have tested positive and either presented themselves to ED or have been sent to ED because people were thinking they could get a sotrovimab infusion. We don't want that happening because it puts too much of a load on ED. So we'd much rather get you refer through this process, and that way my ED colleagues will love you and I will love you too. Next, and please don't send them to us before you've actually referred them. Again, we've had people turn up on the doorstep, and it's really challenging because we can't do a lot with them, and we really need them to go through the proper process. So here's the link. This is the number for the Carlin COVID Care Centre. I can just about say it in my sleep now. Please don't give it to patients because it just is really tricky when they ring us up. And if you can just be mindful of the fact that, we're not unlimited staff. It's a referral service only. And we do have a hospital avoidance GP support element to what we do. We'd like to try and keep people out of ED if we possibly can. And we want to be able to support the GPs who are doing the fantastic work, especially our GPAT GPs. They're just doing amazing work. But I'd like to be able to support other GPs too. Just again, there's limitations on what we can see. We've got 20 beds, so we haven't got unlimited space, and we do accept referrals. And sorry about the acronyms: ambulance, ED, the GP assessment team, COVID response care team, and the South Australian Virtual Care Service, who really are about giving SAS the governance to be able to not transport a patient into ED. Nalan and Salan are now online too, which is fantastic, and welcome into the space, guys. It's lovely to have you. And a lot of the rural LHNs are coming online too, which is marvelous. Eleanor's just said that you can have reviews for ambulatory patients. I apologise, Eleanor, I thought you weren't doing ED avoidance yet, but that's fantastic. If you are, that's wonderful in GP assessment. I don't think the North is doing that yet, so please don't send your patients in there for that. And Women's and Children's, I gather, is going to be looking at setting up an infusion service too, but we're not there yet. And yeah, watch this space. I think that's my bit over and done with.
Thanks, Jackie. Fantastic. That was a very informative presentation, and I think it'd be great to put up some of that criteria on the website as well, rather than just being in the referral form. And I know I've raised that today in another forum as well, now that we're a little bit clearer around some of that. So that's fabulous. And there's been some great commentary in the chat as well. So thank you everyone for posting those. And of course, Eleanor is doing a fantastic job in this space as well. I should acknowledge that. All right, we're going to move now to Renji to give us a bit of an update or field any questions. Renji, I'll come to you next.
I don't have any slides at the moment, Emily, but I'm happy to take any questions. I guess just a couple of things I just wanted to clarify following on from Jackie. With the immunocompromised group, you don't really need risk factors. If they are immunocompromised, then they would be accepted. The logic behind this is essentially, we know that with Omicron, the vaccine, your vaccine effectiveness actually drops off, depending on the kind of vaccine you've received, by anywhere from 4 months to 6 months, with the 2 to 5 months with the mRNA vaccines. So that was the reason why we put that additional definition of partially vaccinated as being beyond 4 months from the second AstraZeneca or 5 months from the mRNA vaccines. There is also data that even with the boosters, there is a wane off over a period of time. Thankfully, our peak actually coincides with the boosters we're getting. So hopefully the boosters will actually keep us going for this period. The logic behind this is people who are unvaccinated or partially vaccinated, particularly with Omicron, not everyone develops severe disease, and especially when we're dealing with a precious commodity, limited supply, we have to give it to people who are most at risk of developing severe disease. So that's why the list of diseases that put you at increased risk. The immunocompromised group is mainly because that's a group that has a blunted immune response to the vaccine. So even if you're fully vaccinated, the expectation is that you wouldn't have developed a full immune response. But again, we've also put a list of drugs that potentially things that we might actually presume would be in that list, but are not, so that we've tried to make it as prescriptive as possible. For example, TNF-alpha inhibitors are not in that list of drugs. But on the same note, if you've had TNF-alpha inhibitors, but you're also on azathioprine or steroids or methotrexate, that would put you at increased risk. So that's why there are some cases that may not be straight, but that once you put the referral through, we can assess that. We might have a discussion with you or the specialist who's managing the patient, and then make a decision. Some of the questions that came through is, what's the time frame by which the assessment will be made? We're making real-time assessments as we go. But remember, these assessments are made during working hours. So if you get a referral at 6 o'clock or 7 o'clock, it'll probably be assessed the next day. If it's a straightforward referral, the patient will get an appointment, preferably most likely the same day. They have a virtual board based on which we know availability of spots in different metropolitan LHNs, and they will be allocated to whichever is available next. In some groups, it might be preferable for them to get, say, for example, liver transplants. It might be best for them to go to Flinders, or renal transplants to Callan. So those kind of decisions will be made at this end. If there's something that you feel is urgent, like the patient's day 6 or day 7, please feel free to call up and let them know so that we can expedite that referral. Happy to take any questions.
Any questions for Renji? I think it's been helpful, I think, seeing questions come through the chat. I think, Jackie, you answered so many things. I think you've really done it for the team and covered a lot of the key aspects and questions. But just for awareness as well, if people do have specific nuanced questions, look, please contact through to the teams, and we can redirect through to Renji or us, another member of the ID team. It's so important we get this right. We do know this really makes a big difference in being able to reduce down some of these admissions coming in, and it's been great to see people being able to stay in their homes. We're talking at the moment, we're at 0.67% of acute admissions, so we really need to keep that number under 0.7 if we're going to have a chance under this 500 bed plan and modelling too. So we need to do what we can with the infusions. I'm going to, don't think there's anything else come through. No, I'm going to move now to Caroline, if that's okay. Just conscious of the time as well, and welcome, Caroline, to see what you wanted to add in from the regional rural aspects. Thanks, Caroline.
Thanks, Emily. Great to see you tonight, and thanks to everyone who's presented so far. I think Jackie's done a phenomenal job, and the team so far. It's great. You've done most of my slides, so I can just get to the bits that I need to. So I'm just going to go into my desktop and share my screen. So hopefully you'll be able to see everything here. And I'll just set my slide. Sorry, just setting my slideshow up. We'll just do it. Yeah, not getting the whole thing, am I? Sorry. We'll just flick it into a slideshow. Sorry, just getting it happening. Here we go. Got it now. Thank you. So for those of you who don't know me, I'm Dr. Caroline Fegan. I'm a GP and rural generalist, and I'm also the EDMS for Riverland Mallee-Currong LHN. And I know some of my GPs are online, so hello. I've been asked to just talk about COVID infusions in regional areas. So it's a little different to metro. And the thing I thought I'd do is step you through how you refer a COVID positive patient for an infusion in regional South Australia. So the first thought was, if my patient's COVID positive, what do I do next? And obviously it's an initial medical assessment. If it's mild disease, assess for risk factors for disease progression, determine if the patient fulfills the eligibility criteria for a COVID infusion. And if they do, then discuss with the patient the option of a COVID infusion. Jackie's already gone through disease severity and the criteria for COVID infusion, so I won't go over that again. If the patient's interested in proceeding, then you fill in the referral form, which Emily and Jackie have both shown, and it comes down my slides in a minute. It's important that they will be sent home from your regional practice, so please give them some information about caring for themselves whilst they're COVID positive and waiting for a call from the regional infusion centre, and to escalate if they become unwell, and notify the patient to expect a call, as Jackie said, from an no caller ID or blocked call number from the COVID infusion assessment team. That's the definition of disease severity and the National COVID-19 Clinical Evidence Task Force, which Jackie's already gone through, and we're talking about mild. Risk factors for disease progression, as I'll just leave it up that Jackie, you've already gone through that, so in the interest of time, I'll skip over them. Patient eligibility criteria, which Jackie has also discussed, and so has Emily and Renji, that to be eligible for a referral for infusion for a monoclonal antibody, the patients must be confirmed as being COVID-19. On this, it still says or by rat, because the update's now with PCR if it's a positive rat, and I'll change that. Being symptomatic for less than 7 days, not have an oxygen requirement, be immunosuppressed as per the criteria in the referral form, or be unvaccinated or partially vaccinated and have a risk factor or risk factors for developing severe illness. And we've touched on that already, so I won't continue that. And if you haven't written down the link for the referral, there it is again. That's what it looks like. And so that's the page that you go to, and you go down on the side here to refer your patient, and this is the beginning of the document. So in regional, what I really wanted to focus on is what happens after I refer. So you're sitting in a regional town, you have a patient that you think is suitable, you have a talk to them, they're interested in the infusion, they've got mild disease, but they've got risk factors. You fill in the referral form, and you kind of think, so what happens now? So I thought I'd go through what would happen there. And Jackie's gone through some of this, and it's a little different for regional. So I just want to touch on that the COVID infusion team and data pharmacists will assess the referral to determine if the criteria is met for a monoclonal antibody infusion, as Jackie's already discussed. For the regional LHNs, the metropolitan, so Cullen, Narlan and Sarlan, have very kindly offered to do the pre-infusion counselling on our behalf. So the regional GPs supporting the regional COVID infusion services are not required to do that pre-infusion counselling at this stage. And I'm very thankful to Renji and the team and Katie to provide that. And Jackie, thank you very much for that, and Eleanor. If the patient fulfills the criteria and agrees to receive the infusion, they'll be referred to the appropriate, so COVID care centre in Metro, or for us, the community outreach infusion services in regional, via an online portal through SharePoint. The receiving regional infusion service, so all the ones that Emily put up before, I've got a list at the end. The receiving regional infusion services check that online portal on a regular basis, often 2 to 3 times a day. And it's usually an RN, so the NUM, or it might be the DON of the site, or the NUM, or one of the level 2 or 3 RNs will be checking it to check that's nominated for the infusion service. We'll check it to ensure any referrals that come through, and then they contact the patient or the substitute decision maker to make a booking for them to attend. We do note, and I've just updated this, Jackie, from the information that you've given, that if there's a positive rat only, a PCR or rapid PCR, depending on how close they are to the 7 days as to whether we do a PCR or a rapid PCR. And one of the tricky components in regional is access to testing sites for PCRs. So there are some dedicated drive-through sites, but mostly it's the GP themselves performing the PCR. So a hot tip, if you're a regional GP and you're referring in and the patient is positive on rat only, it'll be worthwhile doing the PCR at that point when you do the referral to send it in. Or you can get authority for a rapid PCR. The regional GPs are well aware of the processes in each of their LHNs on how they need to get approval for a rapid PCR, and that confirms the COVID positive status. Then in each of the regional COVID infusion services, there's a GP, a rural generalist or other specialist that is nominated or has been organised by the regional LHNs, and they're very kindly, a lot of the GPs and rural generalists are doing this as additional to their work in their practices. They've agreed to be the medical practitioner in the regional areas to provide the infusion service. They undertake a clinical assessment of the patient if they don't know them. So if it's one of their patients, they don't necessarily need to do an assessment because they know them well. But if it is from a neighbouring town or from a neighbouring practice that they may not know, the regional GP would do a clinical assessment just to make sure the patient's safe to have the medication after they arrive. And then we would, in Riverland, Mallee, Coorong LHN, we do written consent. It can also be documented in the EMR. It is possible to also do verbal consent. Renji, are you still happy with verbal consent? Yep, it just needs to be documented. But for Riverland, Mallee, Coorong, and for most of the regional LHNs, we're using written consent. You obviously prescribe it on the medication chart. The pharmacy associated with that infusion service will dispense the monoclonal antibody. The infusion is provided under medical guidance, but not necessarily, as Jackie has already explained, not necessarily by the doctor, but under the medical guidance of the doctor. And then the notification is completed for the infusion being complete through the online portal, and then you send a discharge letter to the referring doctor if the patient's regular GP is not the person who's referred in who's doing the infusion, who then sends your own patient home, which is what often happens in regional. That's the same as what Jackie had up, except it doesn't have the rapid PCR in it, Jackie. I've got the old one. Regional COVID outpatient infusion services. This is a list that Emily put up before. So we currently have them running in Mount Gambier, Riverland in Berry, Murray Bridge, Kangaroo Island, Port Pirie, Port Augusta, Port Lincoln, Cooper Pedy and Ceduna. And after the 20th, they'll be in South Coast, Mount Barker, Gawler and Angaston. Now they may have already been stood up, Emily, and I'm happy for you to correct me, to update that. That was just the information I'd been given late last week. A summary for regional general practitioners and rural generalists is that this is a statewide referral criteria assessment and pre-infusion counselling process for regional general practitioners and rural generalists. The allocation of patients who meet criteria for the infusions to each of the who meet criteria are allocated to each of the LHNs, including all 6 regional LHNs. Every regional LHN does have an infusion centre. Staff at each of those regional LHN sites that are infusion centres are identified to monitor the online portal for referrals, so you don't need to do that. The local outpatient COVID infusion services, and hopefully for the regional GPs that are online, they will have had notification from their regional LHN as to where they are and who might be providing that service, and you may be part of that service. I know there's a number of my GPs in my LHN online and they are part of that service. Depending on the site, it could be a salaried SA health doctor, or it could be the local GP, or it could be a specialist. There's a variety of options in regional for which medical practitioner. It could be a locum that's providing it, an RMO under the support of a consultant. The doctor prescribing the infusion in regional South Australia performs a medical or clinical assessment for suitability if you don't know the patient. So it's similar to like an initial consultation for any other sort of infusion, like an iron infusion or anything else that you'd be doing. You assess them just to make sure that it's safe. You obtain consent, and I've already explained that, and prescribe the infusion. The doctor assessing the patient will often, but not always, be the doctor overseeing the infusion. So depending on the site in regional, a doctor might assess the patient for suitability, but it may not be the doctor overseeing the infusion in the infusion centre. So just be aware of that. And it is most likely in regional that the patient's GP will be the person assessing them. You provide a discharge summary if you're not the local GP and you haven't referred the patient. And regional infusion centres, the critical aspect for this, and I think Jackie covered this in her presentation and touched on it, that regional infusion centres provide an opportunity for all community members, including regional community members, similar access to the COVID infusions. So we've really broken down the tyranny of distance and geography in South Australia to provide all South Australians access to an important medication which reduces risks and outcomes, improves outcomes. And that's the end of the presentation. I'll take any questions that you have. Oh, go.
All right, any questions at all? Where in Berry are we doing the infusions, Caroline?
Oh, good question. We're adaptable, Emily, as you know. We're doing them in the negative pressure pod in Berry Hospital. So, Evan, they're out in the 6-bed negative pressure pod. Not in the ED. That will be his question, because everyone works in for me in ED.
Thank you, Caroline. That's fantastic. And I think we've had some really good comments come through, but this is a fantastic next step in making sure we can deliver care services closer to home. So, and fantastic, you've been actively involved with this and really promoting. So it's fabulous that we've got this up and running. And I think important that people know about the nuances and how it works in the regional rural space. So thank you. Now, Renji's got his hand up. Coming to you, Renji. And apologies, Caitlin, I didn't come to you, so I'm going to circle just back before we end as well. So Renji first.
Yeah, thanks, Emily. I just wanted to clarify that there was a few questions on why we're still doing a PCR if you're rat positive. There's a small proportion of patients who might have a false positive rat, and particularly because we're dealing with a national, probably an international shortage of sotrovimab, we want to try and make sure that we don't waste any infusions and patients don't get infusions of sotrovimab unnecessarily. So Tom's kindly agreed for patients to be able to travel to either the drive-throughs or the Metropolitan Hospital or the regional hospital collection centers. And all the referrer has to say, if they've only got a rat positive test, is to ask the patient to go to the concerned collection center and say that they need to have a gene expert test done because they are being considered for the sotrovimab infusion, and then the center can expedite the test. I mean, there are a number of reasons for false positivity, such as acidity. If you've had some orange juice before the test, there are specific instructions on the kits, but we do anticipate that patients don't always follow the instructions strictly. So you can get, there are good reasons for the false positivity. The kits are actually quite good. They have really good sensitivity and specificity, but it's for these reasons that we do get false positive results.
And Benji, in regional, most of the local GPs would know how to get a rapid PCR for their consumers, and the approval process for each regional, so each EDMS and regional has their own approval process, and they would know how to access that with thankfully.
In fact, if the patient's very early in the illness, like day 2 or 3, you could even get a normal PCR. With the current turnaround times, there's no rush to do a gene expert. It's really for that day 5 and above that we definitely need gene expert, but
that's right.
You know,
And we've certainly done that. We've sent them. We had a patient in Berry who had a positive RAP and hadn't had a PCR, and we sent them through the testing station. And because Tom's done such a wonderful job of reducing the turnaround time, it came back within 24 hours. So we were able to proceed day 4, which was fabulous.
Oh, thank you. That's been very helpful conversation. Thank you. I'm going to, just before I come to Caitlin and Tom, I just wanted to ask you a question, if that's all right, about the self-collected swab drop-off point down south. I feel like I've got it wrong, so I'm going to come to you and ask where that is currently, that someone can self-collect as a GP and go and drop off down to the south, where the drop-off sites were. Kimberly would tell me, but I hoping you know.
So there's certainly one at Flinders Medical Centre, and I'll have to take that on notice. If we've got one further south, we probably.
No, I think it is just at Flinders. That's what I want to check. But whereabouts?
Yeah, no, there's definitely one at Flinders. No, I can't give you that detail. It's terrible.
No worries. Someone else on the line might know. Jackie, you might know.
No, I actually don't. I think it's a state secret, Emily.
Caroline knows. Perfect. Thanks, Caroline.
It's up the back. Oh, am I on? Yep, it's up the back behind Flinders Private. So if you follow the road, if you turn up in front of Flinders Private and go up with Flinders Private on the right, the car park, new multi-story car park, well, it's not really. Go up and have Flinders Private on your right, head up around the back, and it's up the back there. And if you head all the way up the back, you'll get to out the back where pathology, for those of you who are familiar with Flinders Medical Centre, where anatomical pathology is, there's double glass doors, and where maintenance used to be, and it's just there on the walkway as you go in. I've got photos of it, Jack. I can send to you, Emily, if you want to send them around.
Thank you. Thanks, Caroline. That's great. I have read the location and I just didn't pay enough attention. I thought Chrome Road and that was it. So that's great. Thank you. I'm going to quickly close the loop around on some of it. Caitlin, I'm going to come to you if you had any key points you wanted to add, and then I'm going to come back to Jackie.
I don't have that much exciting to say, other than, yes, the guidelines will be up on the front page of the portal, hopefully either later tonight or tomorrow. Which will help provide a bit of explanation and background behind exactly what immunosuppressive drugs are included in that list, and the ones that are also excluded. The other thing I was going to say is, please, the online portal or online referral form, we can't easily change the criteria in there because it will change the data that we're collecting. So if we go in and change a question massively, then it will end up changing the data that we've already collected beforehand. But the criteria that we use may change for the patients who are eligible for infusions according to how much stock we have. So just because one of your patients last week might have got an infusion with a BMI of 30 and no other risk factors other than being immunosuppressed, doesn't necessarily mean that next week a similar patient will get one. It's something that we're going to have to, pay very close attention to according to how much supply of the medications we actually have. But most of that will be done through the back end by our lovely team at Dardis. We'll be chatting to them about what risk factors we consider particularly important, especially for those patients that end up particularly unwell in ICU.
Thank you. Thanks, Katie, for that. Jackie, I'm going to come to you now.
I've just got a couple of quick things, Emily. And the first is you can use these drugs in breastfeeding. Obviously, you need to have a discussion with the woman. You need to talk it all through, but they're not contraindicated in breastfeeding. It's just around the evidence. Don't forget that monoclonal antibodies, we all produce antibodies. They do go into breast milk. These are large molecules as well, and it's only a tiny fraction that goes into breast milk. So please don't assume that women can't have them if they're breastfeeding, but we will have that discussion with them, absolutely. And the second thing is, yes, we have actually absolutely had the situation where we had a woman who had a positive RAT test taken by her GP. Son is also a medical practitioner, and we actually tested the woman again in the car park because I really wasn't 100% sure on the history. It was a negative RAT in the car park. So we then did a PCR on her and it came back negative. And I'm very glad we didn't bring her into the COVID care centre because we would have given her COVID. So it is something we need to be careful about.
Thanks, Jackie. That's very helpful. All right, I'm going to leave it now just in the interest of time, but want to say a very big thank you to Adelaide PHN, to Crystal for all your support in this space, helping us have another webinar within such a short period of time. I think this is incredibly useful for everyone to be able to ask questions, provide our information, and great to see that we can roll out such a widespread Sotrovimab program across the state. We will keep you up to date around stocks and whether we do need to adjust that criteria. Again, if you are going to talk to your patients about it, please provide some counselling around some of the benefits of it. There's a fantastic document as well on the New South Wales Clinical Excellence Commission through the ACI that they've put online, which is fantastic to read through if you want that little bit more in-depth information. We've also got the information as well on the SA Health website, which has been translated into a couple of languages as well. So please encourage you to talk with your patients around infusion so they've got some idea before we call them up from our end around what it involves and in particularly what some of the risks may be and what the benefits are in particular as well. That PCR, of course, as Jackie said, is really important, and being really conscious. You don't need to call up ID at the RAS, so don't need to go through to the on-call. So you'll save some calls through to Renji, which will be great as well. So a big thank you to everyone tonight. Really, really appreciate everyone's support, looking after your patients at the community, doing all you can, and thank you again to Adelaide PHN and our wonderful panellists that we've had tonight. So good night, everyone, and we'll see you next time.